People will join, but it shouldn't have such a big impact because it's a webinar. So welcome and thank you for joining this webinar on the education pathway for MSK Diagnostic Ultrasound. So before you get started, I saw a few people pop up on camera and then they've they've turned that off. If you have got a webcam and are happy to come on board, then we definitely welcome you showing yourself. So there we go. Thank you. Thank you. Nice wave, Amy. Thank you. So, oh yeah, we're getting the salutes in. Very good. Yeah, no, thank you for that. So that just helps with a better interaction. And very quick introduction from me before we get cracking. So I'm Andy Thomas and I'm Director for PhysEquip. So at PhysEquip, we've been providing rehab equipment for the last 8 years or so. And we've been doing focused shockwave. That's been a core part of what we've been doing for the last 3 years, which has been really successful. But as things develop and we've been getting involved with other technologies, we're always looking at what the next thing is and listening to various experts like the guys that we've got on today and reading research. We thought it was best practice to be using diagnostic ultrasounds before shockwave so that you could identify and specifically target the areas that you needed to treat. So this is what I spent about 6 months, the back end of last year, 6 months just looking into different systems, what was going to be a suitable range, and this has led us to taking on the Alpinion MSK range. So it's been quite a long journey for us, and it's been a fascinating area. So before I do introduce the guests, if you do want to ask a question, absolutely really welcome that. So I've been sent quite a few questions, which I'll go through to start with. But if you do have a question, you should have an area where you can type that in. So basically, if you just put question in capital letters and then whatever your question is, and if we've got time, we're going to run till about 6 o'clock, depending on how many questions we've got, then I'll unmute you and you can direct the question to Mark or Chris. So if you could leave your microphone on mute for now, that just avoids any background noise. And then if you've got a question, I can unmute you and you can direct it to one of the guys. So I'm going to introduce Mark and Chris. I'll unmute Mark to begin with.
There we go. I'm unmuted.
So yeah, so Mark Maybury is a research physio and MSK sonographer working for the Rheumatology Research Group in Birmingham. Very experienced, so delighted to, we've only actually met virtually so far, so welcome Mark and thank you for joining us.
Thank you.
And then we have got Chris Myers, who's Clinical Director at Complete Physio and co-faculty lead for the Sports Medicine Ultrasound Group. So Chris has actually run some physical demonstrations for us, which we were meant to have more of those booked in. They've obviously been, they've gone to the side for now. So this is the next best thing. So thank you very much, Chris, for joining us as well.
Pleasure, pleased to be here.
So I'm going to start with the first question, which is the one that we get asked a lot. And I know that when we've discussed things previously. So Mark, if I ask this to you first off, when people say they want to get involved with diagnostic ultrasounds, how do they do that? Where do you start? What's the first step?
I guess the first step really is, and I'd say this, get onto an introductory course. It's not for everybody, and getting training is difficult. You will get some resistance. I've known lots of fairly eminent physios that have tried to get into ultrasound and really have come up against quite a bit of resistance, particularly from the radiology community. Not necessarily the sonographers, but certainly the radiologists are a little bit threatened. And as well as that, it's the management staff as well that you work with. They have to be on board too, and they have to sort of go with your ideas. So it's not easy. It's not as easy as a lot of people think. It's getting easier. When I first started, there weren't many physios at all doing it. I think there's probably, I could name the 6 people that were doing it when I first started, and sort of trying to persuade people to sort of part with cash to come and do the first ultrasound courses. It generated a lot of interest, but then it's almost like we think that at least 80% of the people that did our courses, which we started a group with John Leddy called the Dynamic Ultrasound Group back in 2007, we'd say that we'd have an 80% dropout. Only 20% of people would actually continue with ultrasound. So it's getting easier, but it's still tough.
Right. Chris, anything you'd want to add to that?
So, I mean, what I would recommend is, I've been a physio for 20 years, and I obviously run Smug, which is the ultrasound training company that I run. But from a completely biased point of view, it's stand out the best thing I've ever done as a physio. I'm not sure if I would be as motivated now if I hadn't added diagnostic ultrasound to what I'm doing. So I'm a massive advocate, like Mark is, for people to get involved. But you have to think long and hard before you get involved. Because as Mark said, lots of people want to get involved, but the reality of getting involved is not always that straightforward. So I work in private practice. I did work in the NHS. So if you work in the NHS and you've got other people in your clinic already, and you have a machine in your clinic, you've got a really good support network, and it is quite easy to get started. There aren't many of those barriers. If you work in elite sport, if you work in private practice, first of all, if you work in private practice, you've got to be prepared to commit probably £20,000 into a machine, including all of the training as well. So you might spend 10 to 15 on a machine, and then you're probably going to spend at least 5 over the next 2 or 3 years on some sort of courses, which you have to do. There's no point going on courses other than an introduction without access to a machine. And I would recommend that is a couple of times a week. You've got good access to a machine. And at the same time, there's no point, embarking on too much training in the end if you haven't got a machine. And there's no point having a machine and not then doing the adequate training. So there's lots to think about. It's a massive commitment. So you've got to, speak to people like us that know what they're talking about and have been through the pathway. Otherwise, you're going to come up against a lot of barriers. I know many people that have signed up for postgraduate certificates and have not been able to complete them because they haven't had access to a machine that they thought they would, or they haven't been able to get a clinical supervisor. And clinical supervision and mentorship is one of the biggest barriers that I'm sure lots of people on this call have come across in terms of trying to get started. So that covers quite a few of the issues already, I think, with getting started.
The other thing to think about is that it's not only physios that are clamouring to get training in MSK ultrasound. We tend to think as physios we're pretty hard done by, but actually we have it a lot easier than sonographers. Sonographers have even bigger barriers because the radiologists don't want to let it go to the sonographers. Yeah. So we're the only professional group that has difficulties.
Yeah, and sonographers can't often get a job until they've done the training. And they can't do the training if they can't get the number of scans and the supervision required. So they're in a doubly difficult position. At least as physios, we do have access to patients that we can start scanning, straight away, really, within the context of your competency.
And I guess if you're working with orthopedic surgeons as well, you can work with the orthopedic surgeons and actually get surgical correlation with some of your findings. And some of my colleagues, actually, that's how they started. They introduced a service within a shoulder service, and they got their feedback from the shoulder surgeons about how accurate they were.
Yeah, I mean, that one of the things that you mentioned there, I just wanted to run something. So if everyone, hopefully a poll's just come up there, if you could just answer that question, do you have access to a diagnostic ultrasound system in your clinical practice? Okay, so we'll end that there. So pretty split in terms of who've got access to that. Yeah, I mean, is that when you're speaking to people, is that pretty common, Chris, that you see that some people do, some people don't, and that's a real stumbling block as to what point do they start engaging, whether it's education or whether it is technology?
Yeah, I know, definitely. I mean, without a machine, eventually, obviously, you can't do this thing. If you don't have a machine and you're interested in ultrasound, a bit like what Mark was saying, it is worth going out and doing a 2-day intro course, which lots of different companies will do, just so you get a bit more of an idea about ultrasound. Because a lot of people that come on our intro course, they like the idea of it, but don't necessarily know the reality of it in terms of the training pathway, particularly. What I would say from that poll is somebody that's very biased towards it. If you do have access to a machine, that is one of the main barriers. Certainly if you have access that you're not actually using it, if you've already got access, that is one of the main barriers. So I would really try and push those guys that have got a machine but haven't started their training pathway to get started, because it's very rare that you've got a machine that that's sitting there that you're not using. And I do lots of teaching at Premiership clubs and Championship clubs, and these guys have often got really nice machines that have been sitting there for 5 years and they've not been really using it. And I find that really frustrating, because coming from a clinical background, I think it's very important to be aware that if you're interested in being a diagnostic clinician, that our clinical tests are excellent and we should never take it away from our clinical context, but we are limited with the amount of information that we can get clinically. So I think for those that have got access, I'd really encourage them to get started. And those that don't have access and are thinking about it, then think hard about it and speak to the right people and get the right information before you do embark on it. There's no point really embarking on it if you can't commit to it, because diagnostic ultrasound is just so different to physiotherapy in terms of this is a whole new skill that you've got to learn. This is like saying I'm a physio and now I want to be a sonographer as well as that. So you've got all of that information. But we're firm believers that as clinicians, we're the ones who should be doing the imaging. And that does two things, which I think are really important. One is it keeps the imaging within the clinical context. And probably more important, the more important element of all of this is how you present your scan findings to your patient, the language that you use, and how you put that into the context of the patient's assessment. And those are the two things. And I think a lot of the time when imaging gets a bad press, it's because we're not talking about how much or how we present that information to the patient, because the language that we use matters. And I think ultrasound and the information that you get can be used very positively with your patients.
Yeah, Mark?
Yeah, a phrase springs to mind: beg, steal, or borrow. I first heard that from a German rheumatologist by the name of Wolfgang Schmidt, who's published widely on ultrasound in the rheumatology literature. And that's what he advocates: beg, steal, or borrow if you can't get hold of your own machine. When I first started, sorry, I've just been interrupted by my dog. When I first started, I had to beg the use of the ultrasound scanners in the radiology department, partly because I was treating a lot of the sonographers at the time. And when I muted my idea, or booted my idea around the radiology department, the management weren't particularly keen on me doing it, but the clinician, the radiographers, sonographers were. So I used to go down lunchtime and just scan all the radiology department. I didn't get a machine for 3 years.
Yeah, and this is a question. Both of you guys work with SMUG, and there's other courses that are around there. What are your thoughts on? You've talked about weekend courses, introductory courses, and at SMUG you offer a variety of different ones. What do you think of like the ACC? Have got their postgrad certification. Like, have you got any thoughts around that? I know you're not biased, but you're involved with SMUG. But what are your thoughts about the different offerings that are out there, from university courses to the different other things that are available?
I guess I sit in two camps, because I do help out at the AECC on their workshops as a workshop supervisor, and also work closely with Chris. So I have a foot in both camps. I guess both courses have their place. You've got to start somewhere. And the SMUG courses, or the courses that there are other courses as well, not necessarily SMUG, but you have to be fair and equitable. It's a good place to start. But then you need some form of certification to that, and that's where the educational institutions come in. They have a valid role. It's expensive, and again, you need mentors. And with SMUG, they've got a mentorship program. Not wishing to I've got to plug Chris's mentorship program because it's one of the only ones that's running.
Well, the only ones that run, exactly.
Yeah. And for people that can't physically get a mentor, it's some way of actually starting your training. The best way of learning ultrasound is to have a mentor and have somebody sat on your shoulder going, oh, you're quite oblique on that. Oh, you're not quite longitudinal. You're not quite transverse. Are you sure you know what you're looking at? Oh, you've got some anisotropy there. Move your probe this way, move your probe that way. You don't get that from a book, and you don't get it from watching a video, although it is possible to do that, but you've got to have some underpinning knowledge in order to do that, in order to produce the images. Not only do you have to learn how to use the machine, you've got to learn how to produce the images and what's a good image, what's a bad image. And also then you have to interpret that image. So there's a lot of stuff going on. So it will take you some time. There are a lot of people that pick up a probe say, I don't know what the hell is going on here. You know, it looks like the bottom of the sea or a weather map of Europe.
Yeah.
So
No, I totally agree, Mark. I think both myself and Mark have done a postgraduate certificate. I did mine at Canterbury, and ideally we should be aiming to do a postgraduate certificate in musculoskeletal ultrasound. At present, from a physio point of view, in fact, across the board, it is a very grey area competency, and there is no standard guideline out there. But I think if we all aim to do a postgraduate certificate, then that would be a good start. But at no point do postgraduate certificates guarantee standards, as I said earlier. I'm seeing lots of people ticking boxes of this university course, but actually not being very good at scanning. And that's essentially what this comes down to. The other problem with postgraduate certificates, if we take the money out of it, because you're just going to have to spend money to get good at ultrasound, unfortunately. And the other thing is clinical supervision. So most of the guys on this call will probably struggle to get a supervisor. And without a supervisor, you can't do a postgraduate certificate. And I suppose that's where my motivation came in with some of the courses we've set up with SMUG, is particularly for the private practitioners, which is what I am. You're not going to be able to get an NHS radiologist, sonographer or physio to supervise you. Because as Mark said, you've got the radiologist, the sonography team that also want supervising for musculoskeletal ultrasound. So it is going to be very difficult. So you can do it as a private practitioner, but you do need to try and get somebody locally that's going to help supervise you. And what Mark just talked about there is exactly what ultrasound is about. It's somebody in your ear going, you're not longitudinal on supraspinatus. What are you looking at? Well, what's that? What nerve is that? And it's that constant questioning and reflection of your own scanning and skills that in the end make you good at scanning. Because essentially this is a motor skill. It's just like learning to play the guitar. Yeah. It's the question of sitting down, looking at resources, but somebody actually helping you and guide you through it, and then you going away and practicing it. So the key thing with ultrasound is scan as many people as you can. You know, if you work for a basketball team, scan every basketball player, scan your family, scan whatever you can get hold of, scan yourself. We've all done it. We all scan our elbows and follow what we're looking at. And there's lots of good YouTube resources out there. So you can learn this on your own. And Rob Louse, who I do SMUG with, he literally 25 years ago taught himself, and he's awesome at scanning. So you can do it yourself. But unfortunately, these days, there has to be some evidence and a portfolio of your learning, which has to involve some supervision. Because if somebody says to you, you've just misdiagnosed me, then obviously there's lots of medical legal issues that you need to bear in mind, and you need to cover yourself. So you need to have a portfolio of scans, or what we would call a logbook, which should be around 200 to 250 scans.
And that's variable. It depends on who you talk to. It's not set in it's not set in tablets of stone. Arguably, you need 250 scans of a shoulder to actually get it right. So 250 is really, you were talking minimum numbers, really minimum numbers.
Yeah.
Some the EULAR talk in terms of hours, 350 hours. So.
And that is to prove yourself to a basic level of competency. The process, like any audit process or or any sort of maintenance of competency, it just keeps going. It just keeps going. So you end up with hundreds and thousands of scans, not hundreds of thousands, but hundreds and then thousands.
You have to do a lot, don't you?
You have to do a lot.
And you have to do a lot well. You know,
Yeah.
they say practice makes perfect. Well, that's not true. Perfect practice makes perfect.
Yeah.
That's what you have to do with ultrasound.
And particularly in private practice, often you're on your own and you might be the first one in the practice to actually start scanning. So you haven't got somebody saying you're wrong or you're right. And without that feedback, it's tough. I was lucky I was in the NHS with 3 other guys that still do lots of teaching and lots of scanning. And we just literally spoke ultrasound for about a year. And whenever we had a DNA or we did a quick trigger finger injection, which left 25 minutes after the half-hour slot, you know, or during the half-hour slot, we just started scanning each other. And that really is how you learn ultrasound.
Yeah, I mean, when I first started in my NHS trust, there was me. That was it. I had this harebrained notion that it was going to revolutionise physiotherapy. And when I left the trust that I was working at, we just trained up 8 to take over. So the orthopaedic department recognised the importance of physio scanning in one-stop clinics, so that because of the waiting list for ultrasound in radiology. So why wait when you can have an instant decision? So they ended up investing in training up six physios to scan.
So both of you saying how important it is to have that mentorship. Chris, why do you think, Chris, that you're the only one that's offering that?
So let me. So to pass a postgraduate certificate, you have to do a certain number of scans under the supervision of a clinical supervisor or mentor. And at the end of your postgraduate certificate, the university don't sign you off as competent, your supervisor signs you off as competent. So our mentorship program gives us enough contact days to do enough scans to get someone through a postgraduate certificate. So people that come on the mentorship are either doing the postgraduate certificate or they're using us as a standalone competency pathway, which we feel gets people up to a standard, but we are self-regulating that. And I understand that ideally we wouldn't be doing that, but we have based it on lots of other things. But essentially, and the guys that do our mentorship, and Mark will know this, if we didn't put that forward, they probably would either just be on their own doing it, or they would, because they can't get onto the postgraduate certificates. Mm-hmm. Unfortunately, we do it, or fortunately, we do it at the University College of Osteopathy. Just like at the Chiropractic College down in Bournemouth, we've got that access to patients. So they are scanning real patients with real pathology. And that's why it's very unique, because it's hard to set that up, basically. Yeah.
I mean, the AECC have a unit, like the British School of Osteopathy, they do have patients, and they have regular access to patients. And when you do a workshop there, it's 1 tutor to a maximum of 2 students. So it's labour intensive for the tutor, but also very hard. The tutees have a very hard day scanning because there's no escaping from it. And don't forget, you know, that's only one part of it. You then have to go away in your own time and continue to scan, because it's a motor skill. You have to scan at least. Yeah, you've got to scan daily, really, to get good at it. Even if it's 5 or 10 minutes, you've just got to really put the hours in. Live, breathe, sleep, dream, repeat. Ultrasound.
Should be a t-shirt.
Yeah, it should do, really. You should have it in a mug.
You both mentioned this at different times, but the dynamic of radiologists, doctor, physio, healthcare professionals, have you had any resistance for, say, Chris, within your clinic of radiologists or people that would normally may expect to be referred into, of you doing scans? Have you had any resistance to that?
Do you know what? I've done it for over 10 years, and personally, I haven't had much resistance. And we, you know, on the courses, we have radiologists that teach with us. You know, I go on courses, it's radiologists, physios. I feel there's a lot less resistance than there used to be, like when Mark first started. And I haven't personally come across it, but I'm no longer in the NHS. And I think in the NHS, the issue is that there's lots of people, musculoskeletal ultrasound lists all over the country are booming because everybody is starting to realize that ultrasound is actually really useful and you don't need an MRI for most tendon problems, for example. And therefore there is a boom and there's a lot of training that needs to be done for people for musculoskeletal ultrasound. But that does mean you've got a sonographer trying to get the radiologist's attention. You've got the physio down the road trying to get their attention. So there is going to be competition and probably some conflict in that environment. Personally, from a private point of view, I don't feel it, but generally in the circles in London in private practice, most people know that are interested in this area that, you know, I'm putting myself out there as somebody, as an expert, whatever that means. I've got an ultrasound training company after it. I do loads of ultrasound guided injections privately. So, you know, I suppose my point of that is if you're going to take up ultrasound, you've got to get really good at it. And do you know what? You've probably got to get better than other people at it, because you will be judged, and we will be judged that physios are doing it. I see people on my courses that are physios, but also lots of other professions, and it's not physio specific. I've seen radiologists, I've seen sonographers, and overall I'm very, very, generally the standard of musculoskeletal ultrasound, generally speaking, is still quite low in this country. It's getting much better, but people, you know, come on the course, they're like, I've been doing ultrasound lists, MSK ultrasound lists for a year. And, you know, they can't find the ATFL, they can't find the CFL. So, you know, there's lots of teaching and training to do, but I suppose my message is if you're going to do it, you've got to commit to it. This is 2 to 3 years of your life where ultrasound will be a massive part of what you do. And the other thing to bear in mind is I used to work in elite sport, and I thought I was pretty good at rehab. You know, I still do some manual therapy, but you've also got to be prepared that to commit that time in ultrasound, some of your other skills are going to be sacrificed because of the amount of time it takes to get good at ultrasound.
Yeah.
So I still do lots of tendon rehab, but you ask me to rehab a lower back, I'm definitely not the best person in my clinic for that. And I'm fine with that. I'm happy that I've got these other skills, but you can't do everything. And I think you need to bear that in mind.
Yeah, I think that's a really good point there, Chris. Really good.
Mark, have you seen a change since you started in the acceptance of physios?
I had no issues at all getting accepted, funnily enough, because I was one of the first, and I was viewed as a bit of a novelty. The first course I did was a Philips ultrasound course, and myself and 2 of my friends went up to Newcastle Falcons Rugby Club to do it, and there was lots of radiologists and sonographers, and we were very much viewed as the novelty. Oh, look what the clever physios can do. They don't need an ultrasound scan. They can feel these structures. They know where they lie. So yeah, we were very much a novelty. I've not experienced, well, I guess the only resistance I've felt is from the management, and not physio management. And I know people that have had issues with physio management and using ultrasound. But from the radiology management, really, the radiologists have been that I've been trained by, probably very unusual, because they're incredibly supportive. They basically said, well, if you want to learn to do this, we'll teach you to do it well, but you've got to do it better than we do it, because you're going to be judged as a radiologist. And I've seen some pretty poor radiologists scan, and I know I'm better than them, but I know I'm not as good as the best. So I'm still trying to achieve that.
I think the other thing that Mark's sort of alluded to there is we do have to stay in our box. Okay, so we are physiotherapists. We're not radiologists. They've got a whole load of other skills that we don't have. So I work in private practice. Mark works in the NHS. So the key thing for me in private practice is that I'm not a radiologist. I'm not a sonographer. I only scan something that I would normally clinically assess. Okay, so I don't scan lumps and bumps is the sort of natural thing to talk about there. So if a lump or bump comes into my clinic, I won't even put an ultrasound on it. Like, I'm not interested. It's not a musculoskeletal problem. The exceptions to that would be if there's a small lump off a tendon, or if somebody's been whacked in the quad, then yeah, there's gonna be a lump there and I'd probably scan it. For Mark, who works in the NHS, he's very good at lumps and bumps. John Leddy, who we do lots of teaching with, very good at lumps and bumps. So you've got to know your barriers, and you've got to stay inside your barriers. As soon as you start going out, that's when we give ourselves, as physios that scan, a bad reputation. And there's people doing that.
Yeah. And there will always be the mavericks.
Yeah.
I mean, thinking about sort of the recognition of using diagnostic ultrasound within physiotherapy practice, there are moves within the CSP to try to actually come up with core standards and training. And I guess when John, Gordon Lumsden, Richard Fallows, Dan Doherty, myself, Jane Dixon, and Chris, can't remember Chris's surname, bless, started the Dynamic Ultrasound Group back in 2007. We tried to establish guidelines for physiotherapists using ultrasound. And I have to say, the guidelines are still being established, trying to be established, mainly taken over by Mike Smith. And Mike's liaising with the British Medical Ultrasound Society, with CASE, trying to sort of move this forward within our profession. So there is work ongoing, but it's just taking a hell of a lot of time to sort of get everybody's opinions, to try and come up with a training framework that fits everybody, whether you're an upper limb specialist, a lower limb specialist. We
definitely need that as well, don't we, Mark? We need a competency framework that says this physiotherapist has a basic level of competency in ultrasound.
Yeah.
But that, just because it's not there doesn't mean we shouldn't be doing it ourselves. So if you've been scanning for a year and you don't have one scan logged and images saved, then you've got no evidence of what you're doing, and that won't look very good from an insurance point of view.
And audit as well. I mean, if you're working in the NHS and you're learning to scan, these patients may have had other scans done by imaging specialists. They may have had MRI scans done. So you can audit your ultrasound scan against those known imaging findings, and you can log them.
And it doesn't matter if you're wrong.
No, it doesn't.
You've just got to get right in the end.
Yeah. And then you can reflect on why you were wrong. Yeah. What happened? Did you look at the wrong structure? Did the imaging look at the wrong structure? How does the patient history fit?
So the way I did it for the PG Cert at Canterbury, you do 150 unsupervised scans, which you do in your own facility. And then you have to, we audited 20% of our scans. And those 20% either for me were up against MRI, surgical correlation, or clinical supervisor. And then you do, away from that, the other 100 is supervised. So you've got your supervisor over your shoulder scanning with you. I
must have done 2 years with my supervisor. I was very slow.
Clearly.
I must have logged about over 1,500 scans.
It also, that's worth mentioning is some people just pick this up because it is a motor skill, and it is just like playing the guitar or driving. Some people just pick things up really quickly and they run with it. They just straight away can work out what a longitudinal is, what a transverse, and they can just nail the picture straight away. Whereas some people, like Mark, by the sound of things, and I think I was part of that, it just took me a bit longer.
Yeah.
So driving wise, I was actually very quick at driving.
Yeah, I think there's always a couple of structures that become your nemesis. And certainly the ATFL was one of my nemesises. And getting a really good transverse on supraspinatus. I struggled for years getting it felt like years, it's probably about a couple of months, to get a really good transverse view. My supervisor going, Mark, is that longitudinal or is it transverse? Or are you oblique? I don't know. Oh, you're oblique. Turn it this way. So yeah, it takes a while, but stick at it. It's good fun.
So would that be your advice then? Would you say stick on the shoulder to begin with, knee, a specific joint or area structure?
Yeah. So if you look at the Faculty of Sports and Exercise Medicine and the Royal College of Radiologists, they advocate a modular-based learning structure. And I think that's really important. So there's probably people on this call that just do shoulders, or I know Steve Wells, a podiatrist, who, is just going to do foot and ankle. So if you only do those areas, then your competency is only within those areas. And if you can still do a postgraduate certificate, but all of your supervised scans will only be in those areas. Does that make sense? If you're a physio and you do everything, it can become very overwhelming trying to get good at everything. So on our introduction course, we cover the shoulder because you have to, because ultrasound is awesome for the shoulder, ankle and knee, which are generally slightly easier than elbow, wrist and hip, or slightly more useful. So we generally recommend that if you're just going to do that and you see lots of knees and ankles and shoulders, then for 6 months to maybe 7, 8 months, you're just going to scan them and get good at them and log your scans for that. Then when you get good at that, then you can go on to 2 or 3 other joints. It doesn't mean you don't scan them in the meantime, but you're not concentrating on those areas. And that can sort of break it down into a bit more of a bite-sized competency pathway. And that is advocated in some of the structures that the courses will follow.
I know there's a question, was it from Baring?
Yeah, just unmute, so if he wants to.
Sheffield, yeah, I've supervised somebody who did their course at Sheffield, upper limb, and they seem okay. The examiner that came down to examine me, examining my student, was okay, was very fair. So, and they do lower limb as well, so they do upper limb, lower limb. So my experience of Sheffield, based on teaching somebody to scan, who's one of our lead sonographers, where I used to work, was okay. I don't know what the academic content's like. I guess it's a university module, so it will be accredited.
Steve, to answer your question, I do scan ganglia because I work closely with a foot and ankle surgeon that sends me loads. But a ganglia is a lump or a bump, and not every ganglia is a ganglia. So you have to either be seeing a lot to get good at it, or if you only see one ganglia once every 6 months, refer it on. Because I can tell you now, one of the ganglias in your career will be a giant cell tumour or something different, a schwannoma on a nerve or something like that. Yeah. Guaranteed.
Yeah, I agree with that, Chris. Yeah, I used to work with a foot and ankle surgeon. I used to do a lot of scanning for them. And whenever anything was ever in a doubt, they had an MRI scan.
Yeah. So if you're not going to see a lot of something, you're not going to get good at it. Mm. So for example, I don't scan for direct and indirect hernias in the groin. I could probably do it, but it's quite a subjective area, and I will see I see lots of adductor pain, but I think clinically I can differentiate that away. And therefore I just avoid that area. I don't want to see it. I'll just refer it on to the radiologist down the road who does 10 a week. You know, so you've got to make sure that you stay in your box.
Yeah, interesting about indirect direct hernia. I scan for the NHS on an MSK, and I do an MSK list, and hernias never pitch up. It's always the abdo guys that do it.
Just on to a couple of points that were really interesting there. And this is something that you and I, Chris, have discussed previously. And it's a question that we get asked a lot, and we've heard contradictory ideas on that. So if you're doing any sort of ultrasound scanning, should you be writing up notes on that?
So we get that question all the time.
Yeah.
Mark, do you want to start? I've got mine, but I'll probably waffle on for ages.
Short answer is, in your physio notes, if you're scanning in physio, you write your impression, and based on your ultrasound evaluation. You could say clinical scan, office ultrasound scan, this is what we found, awaiting results. Does it correlate with your clinical findings? You need to document it somewhere that they've been scanned. But in terms of a formal report, unless you've got a PG cert, I'm pretty sure you can't provide a radiology report unless you're working in radiology. I have a foot in about 3 camps, research, well, not physio anymore, mainly research, and I do an ultrasound list. My reports are legal when I work for the NHS. Doing an ultrasound list. As a physio, it's basically an impression. Yeah.
So just to reiterate that, as a physio, you should never be writing a musculoskeletal ultrasound report unless you work in a radiology department where your job is to write an ultrasound report. Okay. As a physio, it is always a clinical assessment and an ultrasound assessment. So in my letters, it says clinically, the patient presented like this, the ultrasound report showed this, and my impression from those 2 things is this. What the other things that people discuss is, so first of all, you can't hide behind not doing a report. Just because you haven't fully got your competency doesn't mean you can't write anything. Just like any note keeping in any medical profession, if you scan them in that session, you've got to write something about that scan. Okay, so, and particularly in private practice, this isn't done a lot. It's like, oh, I did a scan and there's no report. So you do need to write a report. Yeah. The other thing that is really important, particularly in private practice, and Mark might, well, in fact, in the NHS, you've just got to do it, but GDPR has changed things from an ultrasound image storage point of view. And that's another question. Should you be storing your images? And maybe that's another conversation.
That's another kind of word.
We'll talk about that another time because I'll be here all night. But yeah, if you're not going to store them, you've got to make it very clear to the patient that you're not storing them and probably get them to sign something.
Yeah, just a quick one from research. We do a lot of research scanning. We're not connected to PACS because we're not allowed to connect to the hospital's PACS system. So everything has to be anonymized and stored in a safe place, either exported to a hard drive, kept in a locked safe, put on the university's server with limited access. Yeah, it's a nightmare. But everything in research, everything's coded, so it's all anonymized. But we do have a storage issue too. Much easier if we could put it on a hospital PACS, but we can't.
We've got a question from Lee Barnes. Do you want to ask it yourself, Lee? Let's try this.
Hi, Lee. Me and Lee went to school together.
Right.
Hello, Chris.
Hello, mate. How are you?
I'm very well, thank you. And yourself?
Yeah, very well. You still playing basketball? Or we'll do this later, shall we?
Yeah, we'll do this later. Yeah. Thanks, guys. It's really, really useful information you're offering. So thank you so much for putting this on. I'm currently studying an MSc in musculoskeletal physio, and obviously you've expressed how important the clinical mentorship is within MSK ultrasound. Is it also theoretically content heavy as well? I.e., could you combine it with the two, or would you recommend a separate course once?
Course.
See.
Yeah, because you're going to have your ultrasound physics, which is depending on where you do it, it's either a 15 or a 20 credit module. If you have to do professional issues, which is another 20 credit module, and then you've got to do the MSK bit, which is another 20 credit module, and then you've got to do your qualifactory practice modules. If you don't do the qualifactory practice modules, all you've got is a theoretical PG cert in ultrasound. It gives you nothing.
Okay.
It's that qualifactory practice module that you need.
Yeah.
To do that, you've got to do the others. So it's pretty intensive. Take a year.
Yeah. So I mean, I kind of had that in mind already, but yeah, thanks for clarifying that.
Yeah,
that's brilliant. Thank you.
I also thought it was Graham Swan as well, Chris.
That's done
it. I have been told that actually. Yeah.
You're a good dancer.
Oh, top notch.
Thanks, Lee. Thank you. Okay, so again, this is another one that we've discussed previously, but how much of an impact, I'll direct this to you as well, Chris, how much impact has ultrasound had on your physio clinical practice?
I mean, massive. I don't know how I did my job without it. I think the key thing is we all know that you don't have to have an ultrasound scan to get a working diagnosis, which means that you can then get them better. At no point am I saying you can't get patients better without doing an ultrasound scan. But for me, I'm particularly because I do injections, I'm really after that specific diagnosis. And what I mean by that is I believe that it is very hard to clinically differentiate between different structures just from your clinical assessment itself. So some examples for you would be a lateral ankle pain, you know, those sprains that haven't got better after about 3 months. I think clinically it is very hard, and I know this through doing lots of scans and not always being right clinically and actually getting more information. You don't really know if there's a tear in the peroneal tendons, you don't know if there's an ATFL tear, a CFL tear, a sign synovitis, you don't know if there's a avulsion fracture of the fibula, you don't know if there's a talar crural joint problem, etc., etc. And I want to know that information, not necessarily because I need it to get the patient better, but I think that I just want to gain as much information as I can from that assessment, and therefore I feel that I can give the patient the best care. Okay, I'm not saying I couldn't get them better without it, but I feel it helps. It helps me to explain to the patient what's going on, maybe to explain why it's not getting better. Well, we know tendons take a bit longer, for example. But for me, before I embark on treatment, I want as much information as possible. And all ultrasound does is give us more information. But and the biggest shock for me was our clinical assessment is obviously brilliant and we've got to do it. But if you want information about a structure, our clinical assessment isn't good enough. And there's lots of research to support that. Obviously around the shoulder. For example, I had a patient, probably the last patient I saw before we had to close the clinic, was an insertional Achilles problem, rehab. And they had a raging bursitis. And it was so raging and so inflamed, so lots of blood flow on power Doppler. I think there's a high correlation, or it might well be a rheumatological problem. But there was no way that just keep going on that rehab was ever going to get that person anywhere. I mean, they're in a lot of pain. And obviously everybody works slightly differently. But for me, it's just about gaining as much information as we can. And I wouldn't want to do my job without it now, because I want all of that information for me to make a decision on what I should do. And I know that when we first started talking, I've got a massive issue with people just doing shockwave for everything. Everybody seems to be buying a shockwave machine, mainly radial, and particularly for focused as well, where we're putting more energy to something. I believe you have to have that specific diagnosis before you embark on shockwave of anything. So anybody in our clinic doesn't have shockwave unless they've had an ultrasound, because I don't want somebody shockwaving a massively inflamed bursa. Mark, as in your colleague who came down and we did the ultrasound session, he'd been treated with shockwave for his ligament and he had an avulsion of his bone. He had a fracture of his bone, not shown on x-ray, and therefore we just don't know. That's the problem. And the thing I've never liked about physio or MSK is that greyness, and there's a lot of greyness in our assessment. And so anything I can do to give myself more objectivity and more information, I'm totally interested in. And that's in lots of areas of being a physio. But for me, I need that information.
Okay, it's good.
Can't add anything to that. Chris has really summed it up beautifully. I must admit, it's revolutionised my practice. I've literally gone from physio to researcher. I'd never would have done that if I hadn't have done sonography. Yeah,
and you don't know your anatomy. With all due respect to everybody out there, if you don't scan,
you don't know your anatomy.
You don't know your anatomy.
Or rather, you don't know your anatomy well enough.
Yeah, because it just looks so different to the books.
Yeah, it is.
If you're very into MRI, then yeah, you probably do know it. But I was never that into MRI. I'm still not into that much. I'm not very good at reading MRIs.
They look nice. I like pictures. MRI. There's an interesting question that Amir asked, Amir Khan. So hi Amir. Amir's question was, if there's an effusion in a joint without power Doppler activity, would you write in the impression of its synovitis? Well, the answer is no, it's a joint effusion. You could say this, it depends on whether the synovium is hypertrophied, because there is in rheumatology, if you're into your rheumatology, you know that there's a 4-point scale of 0 to 3, which looks at synovial hypertrophy. And EULAR have been working quite actively on producing these grading scales. They also have it for power Doppler, again 0 to 3. So if there was a joint effusion, I wouldn't necessarily write it's synovitis. I'd have to see the synovium, see whether it was thickened or not.
Yeah.
I know it's a bit of a roundabout way of saying no, but
it's a good question though.
Great question, fantastic.
When you work in elite sport, you scan every other knee and they've got a bigger fusion.
Yeah.
but they shouldn't have a synovitis.
Mm.
So that's where your power Doppler comes in nicely. There's a few things around it, but the key thing is, as Mark said, is to look how thick the wall of the synovium, or how thick the synovium is.
But the synovium should only really be 2 cells thick.
Yeah, so you shouldn't really be able to see it, should you?
See a normal synovium should look
Like the paratenon, you shouldn't really be able to see it. It's like the periosteum, you shouldn't really be able to see it.
Yeah. Very good question.
Good question. Never a simple answer.
No, sadly not.
So I'm just going to go back. There was a question from Dominic earlier on. I'm just going to unmute you, Dom. Go for that one.
So just from my perspective, being new to it, is there like a checklist of some kind that you say, right, I need to do this, I need to do so many hours of scanning? Like, what basic things do I need to hit to have a foundation of competency, say, to then move forward?
Mark?
Oh, so I'd say be an ultrasound junkie. Never pass a probe without using it. You really scan yourself, scan your friends, scan the dog if you can catch him. Anything really. I'd just become an ultrasound fiend. But to do that, you need an ultrasound. If you've got an ultrasound scan, that's fantastic. My colleagues at work who were sick to death of me, I scanned them every lunchtime. If I couldn't scan anybody, they'd be grabbed. Any spare opportunity I had, I'd scan them. So
the other thing, Mark, we've got it in our introduction pack for the SMUG course, but it is based on the Royal College of Radiologists.
Yeah.
And actually, the Faculty of Sports and Exercise Medicine have got a nice document that talks about, say, for example, the shoulder. You should be able to scan long head of biceps, supraspinatus, infraspinatus. So it's actually got all the anatomy. So you could go through ticking those, but then you need some evidence of it as well. And that would be the start of that competency.
I think it's good to scan normals as well, just to get your head around to scan a normal shoulder. When I first started, all I scanned was abnormal. So when I saw a normal shoulder, it was abnormal, because everything else I saw was normal. Tears were normal. So it gets you into the idea of being able to use your scan planes and actually work out where the structure is, where its anatomical relation is. So you can then build up your atlas of normal, which you need an atlas of normal.
Yeah,
I call anything abnormal.
I think that's really key. And I did a blog on the site about the sort of top 10 tips for getting started. And everybody on our course wants to scan pathology. And they say, well, I've been scanning all my patients. And actually, what you need to do is take a stage back from that and just start scanning normals.
Yeah.
Because you don't know what, as Mark says, you don't know what abnormal is if you don't know what normal is. And then you end up in this, which is what we see, is a very long spectrum of normal. So you've got your normal, which is like your 18, 19-year-old that hasn't done too much sport, but they don't have too much fat, and you can just see everything nicely. And then you get to 30, my age, 30s, and you've got a little bit of wear and tear. Then you get to Mark's age,
but there's nothing there.
And there's a partial tear in every tendon he's got. And so again, that's how important it is to consider age and clinical context. But the key thing is scan normal to start with. And without that normal, so the key thing isn't to start scanning lots of patients, although you can. It's to get that normal, and that might be your wife, your brother, your son, your friend. And it is useful to get an ultrasound buddy. So if you live near somebody or somebody in the clinic, try and get somebody else to learn with, because that will help a lot.
Right.
The other thing is you get a whole load of normal variations, like when you're scanning the shoulder and the long head of biceps. Sometimes you can see it looks split in the upper section of the bicipital sulcus, but you can get the supraspinatus expansion, which comes down to join it. So you get lots of these sort of normals that we don't tend to learn as physios. Not normal, these sort of anomalies, normal variants, that's what we're looking for. Like bifid median nerves and things like that when you're scanning median nerves.
Yeah, so many. So the books just don't reflect the anatomy. No. I've seen 3 median nerves. I've seen, you just see so much variety, which is normal.
Yeah.
Okay.
Great, thanks.
So we're coming to the end of this now. So I know the answers are quite in depth when we get into them, but from a sort of closing perspective, I know we've covered a lot of information there. Mark, what would your main takeaway message be from this session for people who are looking to get into diagnostic ultrasound?
Find a mentor. Priority. Find a mentor if you can. If you can't, it's on some lists. If you can't do that, you need to do a basic ultrasound course to see whether you're going to like it. A lot of people don't like it. I mean, when I first started, I thought, what the hell am I doing this for? Why am I doing it? But if I hadn't have done it, I do a lot of ultrasound guided injections. I do biopsies. So I wouldn't have been doing that. It's well worth pursuing. It will really change it'll change your direction. It'll improve your patient, even if it improves your patient contact, your patient's experience, and it will save you an awful lot of time in the long run with wasted treatments.
And how would you identify a mentor?
Oh God, again, I'd just be persistent. Because you will get a lot of no's. I can't do that. Because if you think there's the sonographers, there's the registrars that need training, you just have to be persistent. If there's a group of you that, as Chris said, if there's a group of you in the hospital, that makes things a lot easier because you can work together and provide support.
Cool. Chris?
What was the question?
What's your take-home message or messages for people involved?
Look, I'm massively biased. I think it's really hard to do the job that I want to do without ultrasound. I would highly recommend, look, the way I see it is if you've got another 10 or 20 years of your career, then I really think this is worth getting into for lots of reasons that we've probably talked about. One of the reasons what we haven't talked about is the ultrasound machines. So when Mark started 20 years ago, you couldn't see much on the ultrasound machines. They weren't very good.
You could see the ultrasound machine.
What's that?
You could see the ultrasound machine.
Yeah. But it is massively improved over the last even the last 2 or 3 years. You're getting machines that are seeing everything in so much more detail. So as an imaging modality, ultrasound is going to be used more and more. And I think patients are going to have more and more questions about their pathology, particularly as they're starting to get more information about it off the internet. And with the ultrasound, it's going to give you a lot more information to make your diagnosis. And we are limited without it from a diagnostic point of view. In terms of anybody that wants to get started, obviously, I mean, I probably speak to one person on the phone every week about their specific situation, and everybody will have different questions, but actually it's about applying it to what context are you working in, what sort of patients do you see, and the big question we get, which we haven't talked about, particularly in private practice, is how do you monetize this, or can you monetize this? Because you're going to spend absolute minimum of sort of around the £4,000 to £5,000 mark, up to what most of us have spent, which is 20-25k on a really good portable machine. And how you monetize it. And again, that will be specific to the environment that you're working in. So if people have specific questions about that, just as an aside, I monetize it because I do lots of ultrasound guided injections privately. And so that's how I justify spending how I get the return on investment.
I mean, I know we haven't really spoke about ultrasound guided injections, but there's the whole sort of accuracy, inaccuracy trade-off between guided and blind. If somebody say, Mark, you've got subacromial bursitis, what would you prefer, a blind injection or a guided one? I'd choose guided all the time, because at least I know the drug, whether you want to inject the drug or not, is going in the right position and in the right.
And if it doesn't work, you know what it's potentially not, and if it does work,
absolutely,
vice versa.
Yeah.
I mean, maybe it might be worth doing something on a conversation around injections at some point, and particularly, I do lots of ultrasound guided injection teaching. We've just set up a postgraduate certificate at UEL for it, which is the first in the country. It's very popular, but again, knowing what competency looks like around ultrasound guided injections is something that people often ask about.
Yeah, I mean, I think from our perspective, prior to this, we got a lot of questions around technology, handheld, portable, static machines, monetization, probes, all of these things. So I think it may be worth, depending on the feedback we get from this, running something around that area, because it's a never-ending topic, that minefield that you could get into on that. But I know that I'm mindful that we've already hit 6 o'clock now.
Yeah.
So just to wrap up, I want to say a massive thank you to Chris and Mark. It's been really informative from my perspective, so hopefully it has for everyone else as well. If you do have any questions, then Mary, who is on the screen somewhere, she'll wave. So she'll be sending out an email the next day or so with a questionnaire. If you could fill that in, that would be really very much appreciated, because it helps us find out what you want to hear about more, which is ultimately our aim for this. So please fill that in with as much information as possible. We'd love to do more sessions with Chris, Mark, and potentially other people as well. And thank you all for joining. A big thank you to Mary, who's put this whole infrastructure together. So thank you for organising this. And we definitely hope to see all of you very much soon. So Mark, thank you very much.
Thank you very much. Oh, before you go, Steve Wells asked a question, but he put a comment. Not everything you see that is pathological is actually symptomatic. That's another thing to bear in mind. You never treat an ultrasound scan, you treat patients.
Good leading message. Chris, have you got anything as succinct as that to finish on?
Definitely not.
That'll do. Right, thank you very much, guys. Appreciate that.
Thank you.
Hope to see you all soon.
Thank you. Bye-bye now.